All right, so welcome to the 5th tutorial on Krok 2 2016 booklet. Krok 2 2016 booklet. All right. In a rural health care area, there is a case of child dying during the first month of life. During the first month of life. And that is also called what? Neonatal death. Neonatal death or newborn death occurs between the first 28 days of life. So that's what they're referring to. Now, to analyze this situation, among other measures, an expert assessment of medical records is performed. What medical documents should be considered first? So then again, like we said, neonatal death deals with the development of the child for the first 28 days or the death of the child for the first 28 days. So if you really want to analyze perhaps the cause or to know what happened, you have to assess the child's developmental history. Child's developmental history. And so therefore, your answer is what would be A, the child development history. Child development history. All right. A region attended by a central regional hospital demonstrate increased hemorrhagic shock morbidity, increased hemorrhagic stroke morbidity. Essential hypertension morbidity, however, remains at the same level and is below the average level registered within the larger area. What managerial decision should be made in this case? So first of all, you need to understand what all these things are. So when we're talking about hemorrhagic stroke, we are referring to what? Stroke that is developed due to what? Bleeding. Stroke that is developed due to what? Bleeding. And we know that hypertension is one of the leading risk factors for development of what? Stroke, which could be either hemorrhagic or could be, how do you call it? Ischemic. Okay. They can lead to what? To stroke. Hypertension can lead to what? To stroke. But of course, one of the major causes of the major cause, not a risk, I'm telling the major cause of hemorrhagic stroke is what? Intracranial hemorrhage or subarachnoid hemorrhage. That we already know. But of course, over here, what decision are you going to take? We respect that they are having people suffering from essential hypertension morbidity. So over here, for us to manage these cases, what we need to do is to have what we call, we have to be able to detect the presence of this hypertension early and of course, manage it as soon as possible. So over here, our right answer should be what? Should be to design and implement measures for early diagnosis of arterial hypertension. Because if you're able to see it early, of course, you can manage it early and it can prevent what? Complications such as what? Stroke and others. So over here, your answer should be what? Should be C. A 42-year-old man was delivered to a surgical inpatient department with complaints of ecteric skin, pain in the right subcostal area. Biochemical analysis, blood analysis shows total bilirubin of 140. Direct is 112. Direct is 112 out of the 140. On ultrasound, we are having what? A duct of 1.4 centimeters. There is a concrement. Concrement simply means what? Stones. Concrement means what? Stones detected in the distal area. So that means that the bile duct, that is it, the bile duct, at the distal area, there is a presence of what? Of stones inside. Now, gallbladder is 40, but there's no concrement. That means there's no stones in the gallbladder itself. But on the bile duct itself, we are having what? Stones at the distal area. So, of course, what are you going to do? Or what will be your tactics in such a case? So, of course, you want to remove the obstruction because the stone there is serving as what? As a bile duct what? obstruction. It's about that obstruction. And of course, what do you want to do? You would want to do endoscopic papillosphincterotomy.
Papillosphincterotomy.
Sphincterectomy. So please, that is what we're going to do. Why? Because this stone is found at the distal end. When we talk the distal end, we're referring to somewhere close to the papilla and the sphincter. Okay? The papilla and the sphincter. That is where the bile duct and then the ones coming from the pancreas, they all come to meet to deposit or to pass into the duodenum. Okay? That's where they all meet. And they are saying that this stone is found at the distal area. I mean, it is found at that area. So what you want to do is to do the surgery at that area to help you to remove the stones from the duct to allow bile to pass through easily. So over here, we are looking at B as our answer. B as our answer. 4 weeks after myocardial infarction, by now you should know mechanism of myocardial infarction, a 56-year-old patient developed acute heart pain, pronounced dyspnea. The patient's condition is extremely grave. There is marked cyanosis of the face, swelling, and throbbing of the neck veins. Peripheral pulse is absent. Peripheral pulse is absent. Carotid artery is rhythmic, 130 per minute. BP is 60/20. That is quite low. Auscultation of the heart reveals extremely muffled sounds. Percussions revealed heart borders, extension in both directions. What is the optimal treatment tactics for this patient? What is the optimal treatment for this patient? So, of course, this person has already developed what? Myocardial infarction. 4 weeks after myocardial infarction. 4 weeks after myocardial infarction. All these symptoms are now what? Prevailing in the patient. So immediately, what are they going to do? This person is suffering. Don't forget, there is cyanosis of the face, there's swelling and throbbing of the neck veins. That should also tell you that the jugular veins are, one way or the other, are swollen. Okay? It's becoming so obvious over there. So that tells you that the heart could be what? Be failing due to one or two things that is found over there. And they are saying that the peripheral pulse is absent and BP is low. This person is entering into what? Into a shock. The person is entering into a shock. So what you want to do now is to immediately do what? Do pericardiocentesis to check for any fluid accumulation that might be present in the pleural cavity area, for which we're having a reduced ventricular fillings and for which we are having the right heart failure. Because this person is developing what? Right heart failure because of what? The neck stuff and then everything that is happening. Everything is moving down. And ventricles are not pumping enough blood. That is why the BP is low, 60/20. The ventricles are not working very well. So at the long run, you could see that we're having not even the right alone, but even the left heart is also what? Failing. So in general, we're having what? A heart failure due to this MI or this myocardial what? Infarction. So over here, you would want to do a pericardiocentesis and immediate thoracotomy. We discussed these things. Thoracotomy. You want to open up the person and make sure that you can stabilize these hemodynamic disturbances. Stabilize these hemodynamic what? Disturbances. So that's what we're going to do in this case. So therefore, your answer should be what? Should be E. Or our answer should definitely be E. Our answer should definitely be E. All right. A 45-year-old man was delivered to a hospital with complaints of vomiting with streaks of blood. There's loss of weight. Okay. Esophageal Fibroscopy revealed what? A cauliflower-shaped mucosal growth, which was detected in the abdominal esophagus. So whatever it is, it's happening at the esophagus. Happening at the esophagus. Now, when we talk about a cauliflower shape, just like when you have a tumor in the uterus, they can describe it, or in the cell, they can describe it as what? As a cauliflower appearance. This cauliflower appearance is a sign or it's an indication for a tumor. A cauliflower is an indication for a tumor. And again, looking at the analysis again, we are having what? Weight loss. And of course, tumor can also lead to what? Significant what? Weight loss. And they said the mucosa, there are bleedings on contact. What diagnosis can you be thinking of? And of course, over here, we are definitely going to be looking at what? At a cancer of, or a tumor of the esophagus. A tumor of the esophagus, which of course, don't forget, not all tumors develop into a cancerous process. But definitely, this case, you might end up developing a cancer eventually. Might end up developing a cancer. All right, so over here, we are looking at what? Esophageal tumor. Esophageal tumor. 35-year-old man complains of intense lumbar pain irradiating to the inguinal area. Is Damilola around? Dami? Okay, she's not around. Fifi, do justice and call her for me. External genitalia. Tiredness, frequent urination, chills, nausea, vomiting, positive Pasternatsky symptom. That is what? Costovertebral angle tenderness is present. And we've had some kind of differential when it comes to what? Costovertebral what? Tenderness. Apart from the fact that we're having a problem with what? We're having a case of pyelonephritis. Now, the reason why I mentioned that is because of pyelonephritis. Anytime I remember pyelonephritis, I remember tummy. So pyelonephritis, or we can be thinking a case of what? Of Aphons in this question. So these things start coming to mind. When I say Aphons, I'm referring to what? To kidney stones. Exactly. I'm referring to kidney stones. So basically, that's what it is. So urine analysis revealed that RBCs and WBCs covered the total field of microscope. The urine exhibited high protein concentration. These clinical presentations were most likely caused by the following pathology. So if you look at the option that we are having over here, you can boldly look at it. Intense lumbar pain. Intense lumbar pain. That is radiating to the inguinal area. Then goes costovertebral angle tenderness. All of these things are indicating that we are having what? A renal colic or urolithiasis. Urolithiasis. Or sometimes I see the question mid slopes. It's also an indication. All right. A 20-year-old patient complains of pain in the left lumbar region. Pain in the left lumbar region. Arterial pressure 160, 110. Ultrasound revealed that the structure and the size of the right kidney were within age norms. So kidneys have no problem. There were signs of third-degree hydronephrotic transformation of the left kidney. So I mean the right, no problem. But on the left, we are having what? We are having hydronephrotic transformation. That means more or less like a dilatation of the renal what? Pelvis and the calyces. Perhaps due to maybe fluid or something like that happening there. Water. Doppler examination revealed an additional artery that is running to the lower pole of the kidney. Excretory ureogram shows a narrowing in the region of the uteropelvic junction. Someone was asking me today, what is an excretory ureogram? So basically, this is used to check either the kidneys, the ureters, up to the bladder area. Up to the bladder area. So you used to check that whole path. So basically, the upper urinary tract, check for any sort of obstruction, whatever it is. Now, specify the treatment in this case. Now, we're having a case of third degree hydronephrotic transformation. So definitely, you will want to do what? Do a surgical what? Procedure. You will want to do a surgical procedure. And of course, the most common surgical procedure that you do is pyeloplasty or pyeloplasty. Pyeloplasty. So it's more or less like you are repairing the place. You drain whatever it is, then you repair the place for everything to move on smoothly. And that's over here. We are going to look at what? At a surgical intervention. A surgical intervention. Don't forget again, they are telling you that there's what? There is narrowing. There is narrowing in the region of the uteropelvic junction. So what you want to do is to open up or repair the place. And the process or the procedure is called pyeloplasty or pyeloplasty. Anyhow you want to pronounce it. Just get it right. So there is surgical intervention. So your answer is A. As a result of a load lifting, a 68-year-old woman developed acute pain in the lumbar region. Acute pain in the lumbar region. In a buttocks, posterior lateral surface. Posterior lateral surface of her right thigh, external surface of the right shin, and the dorsal surface of the foot. So there are pain in all of these areas. Objectively, there's weakness of the anterior tibial muscles, long extensor muscles of the right toes, short extensor muscles of the right toes, low Achilles reflex on the right. And they've told you that there's a positive LASIK sign. What examination method would be most effective for specification of the diagnosis of L5 root discogenic compression? Definitely, for us to say that there's a LASIK sign, some books or some question will tell you there's a straight leg raise. Straight leg raise. All of these things are all examination to check for what? A herniated disc in the lumbar region or herniated disc in the spinal column or the vertebra. And mostly we are talking about what? The L5. We are talking about the L5. And of course, a positive sign also tells us that we have what to call what? A lumbosacral radiculitis. We've done this thing, so I'm just echoing it in your ears. We have what? A lumbosacral what? Radiculitis. So now the question now is that what would give us an effective way of what? Diagnosing this patient? I know many of you be thinking about what? Spinal column X-ray. Spinal column X-ray, because of course, an X-ray is what we use to check for the presence of all these herniated discs and things like that. However, if you want a detailed confirmation or a detailed information about what is really happening, you have to do a magnetic resonance scan. Magnetic resonance scan. That would be best when it comes to what? Being effective. I mean, giving you a detailed information about what is happening at that root or the L5 root. Okay. But of course, normally we do what? A spinal X-ray. We do a spinal X-ray to check for some of these things. But for vivid description, you need what? An MRI or magnetic resonance scan. Magnetic resonance scan. That's over here. We can go in for the A. All right. A 23-year-old female has been suffering from mental disorder since the age of 18. Mental disorder. In the course of this disorder has no remission period At hospital, the patient mostly presents with a non-purposeful, foolish excitation. She makes stereotypic crimes, exposes herself publicly, masturbating, loudly laughs, repeating stereotypical. Why are people laughing now? But the question now is that what are you going to prescribe? This person is definitely what? They've already told you that diagnosis person have mental disorder, and exhibiting all of these things. These are signs of what? Psychosis. And if they are signs of psychosis, you need to give what? Antipsychotic drugs. And if you want to give antipsychotic drug, we are referring to what? Neuroleptics. Exactly. Neuroleptics. And that's what over here, your answer is D. Your answer is D. Who will be masturbating and want the whole world to see that he's masturbating? Anyways.
If
it turns. During preventive ultrasound scan of abdomen performed during regular checkups in a school, the following was revealed in an 11-year-old student of the 5th grade. 11-year student of the 5th grade. The left kidney is 3 centimeters below the normal position. Its shape, size, and structure are within the norm. The contralateral kidneys cannot be observed at its proper place. The preliminary diagnosis is as follows. Guys, look at the diagnosis. We are having what? A congenital abnormality of the renal development. Congenital abnormality. There is what? Dystopic left kidney. The right kidney is absent or pelvic dystopic. What X-ray method would be required for making the final diagnosis and determining the functional capacity of both kidneys? So now if you want to check, now I'm talking about the nephron, where you have to, the golden standard for checking the nephron, of course, checking the functionality of the kidney, you already know that it is what? Is the creatinine, isn't it? To make sure that the kidney is functioning properly. But an X-ray to check the functionality of the kidney, we use what? Scintigraphy. We use the scintigraphy. Excretory urography, like we discussed, is checking for possible what? Obstructions in the kidney, the upper kidneys, or let me say, the upper urinary kidney or urinary system. Let me put it that way, urinary system. Okay, that one used what? The excretory urography. But over here, we are looking at what? The functionality of the kidney. And don't forget, this patient has already been diagnosed with a congenital abnormality. So you want to look at the functionality of the kidney. And so therefore, we have to use what? A scintigraphy. So your answer should be C. Renal dynamic scintigraphy. All right. A young woman suffering from, this is, I think, Juma. This is your question. So you answer the question, Juma. A young woman suffering from seborrhea oleosa has numerous light brown and white spots on the skin of her torso and the shoulders. The spots have clear margins, browny desquamation, no itching. What provisional diagnosis can be made? Juma, what's your answer?
Petrasis vesicular.
Exactly. And I think we had a nice discussion on this topic. That's why I asked him to answer, because he, one or the other, agreed with Krok that yes, this could be so. And I was having the fact that this is a type of a seborrheic what? Dermatitis. That's what I was thinking. But he came out to give us some information, the fact that we could be looking at what? Pityriasis vesicular. So please, if you are not there, do well to watch the explanation. On it. We discussed it at length. It was I disagreed it, but we later on settled for it to be correct. So the answer is what? Is D, not seborrheic dermatitis like I was thinking. All right. In a traffic accident, 2 persons died. An appointed forensic medical expert was called on duty to another accident location. Therefore, according to the criminal law in force in Ukraine, an investigator called in the following specially for examination of the location. Guys, what they're trying to tell us is that in the absence of a forensic medical expert who can also tell us if the person is dead or not, who else among these people can tell us if or can confirm the death of people? Of course, every medical doctor, yes, yes, should be able to do that. Every single doctor should be able to do that. So here, the nearest available medical doctor can do it. So your answer should be B. A patient is 28 years old. He has been suffering from a mental disorder since he was 22. His current condition has changed acutely. For 3 days, the patient has been refusing to leave his home. Why? He claims that there is a telepathy occurring. Now, when we talk about telepathy is referring to a supposed ability, okay, to perceive the thoughts of others without the use of recognized senses. I repeat, the ability to perceive the thought of others. Like we are talking now, maybe I can know what maybe Nene is thinking about right now. I can know what maybe Kalila is thinking right now. These are the kind of thoughts this person is having. So he claims that there is a telepathy occurring between him and other people. So he's thinking that people are taking his thoughts, isn't it? Now, through which, now look at it, the reason. So he believes that he claims there is a telepathy occurring between him and other people, through which he receives, he's receiving thoughts of strangers. So now he's beginning to receive thoughts from people. I'm beginning to think how you are thinking. I mean, I know what you are thinking. And transmit his own thought for everyone to hear. So again, he doesn't only perceive that he's receiving some strange thoughts, he's also thinking that he is transmitting those thoughts for everyone to hear. And he thinks his thoughts and actions are manipulated through this telepathy, make the preliminary diagnosis. Guys, this person definitely is going through some mental issues. And over here, we can describe this phenomenon as a paranoid schizophrenia. Paranoid schizophrenia. Because in paranoid schizophrenia, we are thinking about delusion, we are thinking about hallucination, and so many things. And we are thinking that we think something is real. Meanwhile, the thing is not really there, or it's not real. Something like that. So that's why over here, we are going in with the paranoid schizophrenia as our answer. So your answer here should be what? Should be E. All right. A 40-year-old patient is registered in a narcological dispensary. Somatically, the skin is dramatically hyperemic. Guys, note, narcological dispensary is not there for being there sick. The skin is dramatically hyperemic. Sclera are injected. Hyperhidrosis is present. BP 140/100. Heart rate is 100 per minute. Mental status, we're having what? Autopsychic orientation is intact. Allopsychic orientation is distorted. Patient presents with motor anxiety. There is an expression of fear on his face. He refuses to talk about his problems and asks to release him immediately because he may be killed. This state developed in a day. Guys, look. This state developed in a day after one of his regular drinking bout. Narcological dispensary. What is your provisional diagnosis? So, guys, what are you thinking about? What are some of the for what condition? Exactly. Delirium. Because of what? Withdrawal syndromes. Withdrawal symptoms. isn't it? So when they are withdrawing from it now, because nobody is there to give him, because in the hospital, will not continue to give you drinks. I mean, the alcohol to be drinking, whatever it is. And from the occasion, he has been abusing these drugs. So staying away from it is causing all these problems. So we're having a delirium tremens due to alcohol withdrawal syndrome. So your answer here is A. A 35-year-old female patient has gained 20 kg within a year with a normal diet. Diet is normal, but gain weight. She complains of chills, sleepiness, dyspnea. The patient's mother and his sister are corpulent. Height 160, weight 92, BMI 35.9. What stage of BMI is this? Or what of BMI is this? Is it type 1, type 2, type 3, whatever? Stage 1, stage 2? Who can tell me? BMI? Oh, you have forgotten.
Stage 2.
Stage 2.
Okay, good. Obesity is uniform. There are no stria. Anytime I remember stria, I remember Uche. The face is anemic. The skin is dry. The tongue is thickened. Heart sounds are muffled. Heart rate 56, BP 140, 100. Patient has constipation. Amenorrhea for 5 months. Now they've mentioned what? TSH. Now, when they mention TSH, you start thinking about problems with these kind of people. Craniogram shows no pathology. That means there's no problem in the head. Craniogram. That means the skull. Nothing is wrong with the skull. So what is the etiology of obesity in this case? Now, assuming you don't know the normal rate of TSH or this stimulating hormone, okay, or thyroid stimulating hormone. Assuming you don't know so now assuming you don't know the normal range. So now you are thinking, are we talking about hyperthyroidism or we are talking about what? Hypothyroidism? That's what should come to your mind. That should come to your mind next. And of course, in hyperthyroidism, all of these ones will be the opposite. In hyper, of course, there will be weight loss instead of weight gain. There will be weight loss instead of what? Weight gain. So all these things comes to your mind. Now, when it comes to cortisol level, definitely you'll be thinking of what? A stria or stretch marks. That's what I'm saying. When I remember this question, I remember Uche. Do you understand me? So over here, we are obviously looking at a problem with what? Hypothyroidism. Hypothyroidism. Because in hypothyroidism, there's what? Decreased thermogenesis. And there's also a decreased metabolic rate. There is decreased metabolic rate. That means things cannot be going on in your body as it ought or as they ought to go. So over here, we are looking at hypothyroidism, and so therefore hypothyroid is the etiology of the obesity in this case. So your answer here is C. Your answer here is C. Now you can't say this alimentary because diet is normal. That's what they brought it over here. Diet is normal. Diet is normal. All right. A 10-week pregnant woman was admitted to a hospital for recurrent pain in the lower abdomen. Recurrent pain in the lower abdomen. Bloody discharge from the genital tracts. The problem developed after a case of, upper respiratory tract infection or upper urinary tract infection? Which is which?
Upper respiratory.
Okay. The woman was then registered for an antenatal care. Okay. Speculum examination revealed cyanosis of the vaginal mucosa, clean cervix, open cervical canal discharging blood and blood clots. The lower pole of the gestational sac was visible. What tactics should be choosing? First of all, what is your diagnosis in this? What is happening in this patient?
It's already abortion.
Exactly. Abortion. Abortion is happening. Open of the cervical canal, discharging bloody and blood clots, discharging blood and blood clot, gestational sac visible. And they said this person was registered for antenatal care. Antenatal care is when you're pregnant and you start taking care of you. That means one or the other, they've confirmed pregnancy, isn't it? So, and again, they've told that this person was 10 weeks pregnant. So all of these things tells you that abortion is already what? Taking place. No matter what this woman will do, the abortion will happen. Okay. So of course, what are you going to do in this patient? You do what? Your DNC to remove everything from the womb. Do your DNC to remove everything from the womb. And that's over here. We are looking at what? Curettage. Now, Uche was asking for different types of the abortions. Please go and open obs and gynae basis. Otherwise, I'll kill you.
I don't watch them now.
Good. Otherwise, I'll kill you.
I don't watch them.
Very good. Okay. But don't worry, I'll get you guys a preamble that can easily tell you, for example, that we're dealing with cervical. There are some, we classified according to what? Vagina opening, according to pains, according to clots that are coming and things like that. So I'll look for a picture and I'll send it to you guys on the group page. All right? To just summarize everything for you. And again, you guys have to just remind me. So over here, we're looking at what? A curettage or curettage. A patient with fibromyoma of the uterus of the size up to 8 to 9 weeks of pregnancy consulted a gynecologist about acute pain in the lower abdomen. Examination revealed a positive symptoms of peritoneal irritation. That is that peritonitis could be present. High leukocytosis, again, it tells you that infection is taking place. Vaginal examination revealed that the uterus was enlarged, corresponding to 9 weeks of pregnancy. So that means the fibromyoma is looking as if we're having a pregnancy of 9 weeks. And again, they've told you due to the fibromatous nodes, one of which was mobile and extremely painful. Appendages were not palpable. There were moderate mucous discharge. What is the optimal treatment tactics? What is the optimal treatment tactics? Again, we've taken a number of times that most fibroids do not require any treatment. It can just go on its own, doing surveillance or by using conservative for treatment. It will just go. But this nature of fibroid demands a removal or a surgery to remove the fibroid from there. So over here, we are thinking of what? We are thinking of what? An urgent surgery. Urgent surgery. So you open the person up and you move. Don't go and do laparoscopy by using a camera, because this one is quite severe. So you need the whole abdomen to be open for you. The pelvic area to be open for you to remove that fibrous tumor or the fibromyoma. We've discussed this thing. So a 4-month-old child was admitted to a surgical department 8 hours after the first attack of anxiety. 8 hours after first attack. 4 months. Now the attacks happen every 10 minutes and last 2 to 3 minutes. Vomiting occurred once. So we are having what we call intermittent sort of abdominal pain. Okay. Intermittent abdominal pain. And these kind of things are very, very common. With children like this, they are very, very common in some people. However, let's continue the discussion. They said the child's condition is grave, abdomen is soft, palpation revealed a tumor-like formation in the right iliac area. So again, they've told you where the problem is. They've told you where the problem is. So definitely we're having intestinal obstruction. We are having intestinal obstruction for this baby. Now, after rectal examination, the doctor's finger was stained with blood. What is the most probable diagnosis? Guys, what is your answer? We've discussed this.
Ileocecal invagination.
Exactly. Or intussusception. That's another name. Intussusception. Intussusception. So over here, we are looking at what? At C as our answer. Again, we have done this in our base or in the basis for obs and gynae. So your answer here is what? Is C. Who can tell me the kind of vomiting you might see in pyelostenosis? Who can tell me? Oh, you have forgotten.
Projectile.
Projectile. Thank you. All right. Now, a woman has focal encephalitis. That means brain infection. In the anamnesis, her spatial orientation is not disrupted. She has a sensation as if everything seems surreal, meaning that buildings are, that means this is how she sees things. Buildings are small, they are round or distorted, trees are upside down, people are very tall with thin limbs. What sort of psychopathologic syndrome is it? Of course, we are looking at what? Derealization. Derealization. And the word derealization is simply a feeling that one's surroundings are not real. One's surroundings are not real. And again, they feel the buildings are small. They feel that people are too tall, blah, 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 blah. So all of these things, it means that the person is feeling that the surroundings are not real. So this is kind of English, even though it's a mental disorder or mental disturbance. All right. So that is what A. Now, in depersonalization, it talks more of a feeling of being disconnected from your body or detached from your body. That feeling, you feel like you are not the one talking or you're not the one doing these things that the person is doing. Meanwhile, you're the same person, but you feel like you're not the person. So you are more or less like detached from yourself. And hence, we call it what? Depersonalization. But that's not the case in this case. I mean, in this question. So your answer is A. A 56-year-old woman complains of itching skin of her torso, constant nausea, constipation, sensation of heaviness and pain in the right subcostal area, extreme general fatigue. The patient suffers from biliary cirrhosis, so scarring in the biliary duct or biliary cirrhosis. The skin is pale, ecteric, abdomen is soft, liver protrudes 2 centimeters from under the margin of the right costal arc, sensitive on palpation, total bilirubin 142, conjugate 139, alanine aminotransferase 0.9, aspartate 0.8, alkaline phosphatase 8. What drug should be prescribed in the first place? What drug should be prescribed in the first place? So now, if you look at the things that are occurring in this question, the kind of thing that you would need, or if I should say, so now technically we are having what? Biliary what? Cirrhosis. Now, if you're having biliary cirrhosis, that means things are not functioning properly at that what area, or the cells that are supposed to be there to help things to function properly, unfortunately, they are not there. The enzymes will be defective. Everything will be what? Defective. And that is why we are having these sort of things being described in this patient. And if I may ask, what kind of jaundice is it? Is it pre-hepatic, hepatic, or post-hepatic? Who can tell me? This is going to help you. That's what I'm asking you. What kind of jaundice? Is it pre-hepatic, post, or hepatic?
Hepatic.
I think it's post.
Hepatic, post. This is post. We're not having a problem. Guys, listen, we're not having a problem with the liver. Biliary cirrhosis has to do with what? The biliary tract. That means this one has moved from the liver. And even if you look at the AST, ALT, of course, you need to know the normal values. But I think in Krok, if you check at the back, you will see the normal values at the back in Krok. They have those kind of things over there. These are normal. And when these things are high, these AAT, SAT are high, it means that there's a problem with the, how do you call it? With the liver. It means there's a problem with the liver. And then if you look at it, total bilirubin is what? 142. And conjugated, that means it has already passed through what? The liver. We are having 139. And we said that in hepatic, we might have slight difference between conjugated and non-conjugated, isn't it? Now, in post-hepatic, the conjugated ones are extremely more, or they are more than the unconjugated. That means over here, it's only 3 micromole per liter that are what? Unconjugated. So over here, we are looking at the problem with what? Post-hepatic or obstructive kind of what? Jaundice, or mechanical or mechanic type of what? Jaundice. So that means that there is what? An obstruction in this patient. And that obstruction could be because of what? The biliary what? Cirrhosis that is taking place and stuff like that. So over here, what we need, or the drug that can help us here, is what we call Osodiol. And this Osodiol is actually a naturally occurring bile acid. Naturally occurring bile acid. And this is used to dissolve cholesterol. It is used to dissolve cholesterol and for treatment of gallstones and, of course, cholecystatic forms of liver diseases that might even include biliary cirrhosis and things like that. Do you get me? So that's what we're looking for. We're looking for what? A bile what? Acid. A bile acid that can help us to treat some of these conditions that we are having in this patient. And that's over here. And then for the osodiol, it's what we call the deoxycholic acid. Deoxycholic acid. It's the same as diol. Again, this is a what? A bile acid. So definitely it will decrease the cholesterol level and helps with digestion of, fat and things like that because it contains bile. So that's what over here we are going to be looking at. And don't forget, these patients also have what? Constant nausea and constipation. That means the things know they go. Food know they go. They're not being digested for it to be what? Perhaps be excreted. And even if you get excreted, you might end up seeing what? Fat inside the stool. All right. So over here, we're looking at what? D as our answer. D as our answer. A 40-year-old female patient complains of having a bulge on the anterior surface of the neck for 5 years. So again, if I were you, I'll just put or place my right hand on my neck. So the anterior surface. So what organ are you looking at for? Good. Objectively, pulse 72 per minute, arterial pressure 110 per 70 in the right lobe of the thyroid gland palpation revealed a mobile node with this size. The left lobe is not palpable. The basal metabolic rate is 6%. What is the most likely diagnosis? What is the most likely diagnosis? Guys, what can you think of? What is the diagnosis? And why? We've done this. So anyone can answer. Or I should mention names. So first of all, are we having signs of hyperthyroidism or not? Oh.
Not. We are not having.
You're not having any sense of, why are you guys afraid of me? There are no signs of hyperthyroidism present.
Yeah.
No signs. So if there's no sign, what comes to mind?
Thyroid. Nodular
Thyroid. Exactly. So first of all, you have what? Euthyroid goiter. But again, what is the characteristics of this goiter? Is it diffuse? Is it mixed? Is it nodular? Is it what? And of course, your answer is staring at your face. So this is what? Nodular euthyroid goiter. That is how to analyze a question. Don't forget that. That is how to analyze a question. Other than that, you might get confused. So please, your answer is what? Is D. Nodular. Why? Because we're having what? A mobile node or nodules. Yeah.
About what's euthyroid?
Euthyroid means non-toxic. Non-toxic means euthyroid. Non-toxic. That means now, if enlarged or if a goiter comes with signs of hyperthyroidism, we call it what? Toxic. But if it doesn't come with signs of hyperthyroidism, we call it what? Euthyroid or non-toxic. So non-toxic means even though it is there, but it's not causing much harm. All right. And don't forget, the patient is always complaining that he's having what? A bulge on the anterior surface. It's not as if the person is sick or something. He's just having a swelling on the neck. So over here, we're not having constipation. We're not having weight loss. We're not having tachycardia. We're not having all those stuff. So it is what? Non-toxic. Euthyroid. Estimation of community health level involves analysis of a report on diseases registered among the population of district under charge reporting form 12. What index is calculated based on this report? What index is calculated based on this report? Let me read the question again. I'm getting confused myself. They say what estimation of community health level involve. Okay, so we're talking about analysis of a report on diseases registered. On diseases registered among a population. So of course, you are going to be looking for what? For the morbidity rate. Morbidity rate. Morbidity rate means what? Disease rate. Disease rate. Now, you might confuse yourself with what? Index of morbidity with temporary disability. No. We are not referring to what? Temporary disability. In temporary disability, it means that we are asking this person not to go to work or not to do some activity, to rest. That is what? Temporary what? Disability. But this question is not referring to such cases. It's just referring to what? How to analyze diseases occurring in a given what? Population. That's all. So over here, we're looking at what? The morbidity rate. The morbidity rate. And so therefore, your answer should be what? D. Morbidity rate. A 32-year-old woman addressed a dermatologist with complaints of slightly itching rashes in the mouth angle. She has been suffering from this condition for 3 good years. Objectively, there are isolated small phalanx and superficial erosions covered with honey yellow scabs. First of all, who can tell me a disease with this description? Honey yellow. Have you guys heard of anything? Come again?
Herpes.
Not necessarily herpes. Herpes is a viral infection, not necessarily herpes. Have you heard of something about impetigo?
Yeah.
Oh,
I said that, Dr. BAHA.
Come again?
I said impetigo.
Oh, I didn't hear. I didn't hear.
I didn't shout loud enough today.
Sorry, I didn't hear you. So basically, you are thinking of more of what? Impetigo. You're thinking more of what? Impetigo. However, let's do the question. So we're having what? Against the background of slight hyperemia. Definitely there's inflammation, no doubt. Now make the diagnosis. So again, the honey yellow scabs against the background of hyperemia tells us that we might be having a case of what? Impetigo. We might be having a case of what? Impetigo. And impetigo is caused by either staph or strep infection. Staphylococcus aureus or wait, is it Staphylococcus aureus? Yes. And strep pyrongis, right? Or I'm getting confused.
Yeah, that's the one.
Yes.
Good. So I think of these two cases being the causative agent for what we call impetigo, isn't it? So over here, what comes to mind as your diagnosis, even though there's no impetigo, whatever it is, we can go for what? Streptoderma. That means strep infection of the skin or streptococcal infection of the skin. As simple as ABCD. And again, of course, in strep, a lot of diseases a lot of these skin infections are caused by streptococcus or streptococcus, basically. And that's over here. We are looking at what? At E as our answer. Yes, you might be thinking of dermatitis, which one word the other also means what? Inflammation. Inflammation of the what? Of the skin. Know that about that. We can be accompanied with itching and stuff and things like that. But over here, it's quite a bit different. Now over here, we're even having erosions. We are having some pars formation, things like that. All of these things happening. Because this honey yellow is more or less like pars forming, isn't it? That's over here. We are looking at what? Streptoderma as our answer. Streptoderma. Now, after a contact with chemicals, now when I remember this question, I remember Fifi. After a contact with chemicals at a plant worker has suddenly developed stridor, voice hoarseness, barking cough, progressing dyspnea, objectively revealed acrocyanosis. What is your provisional diagnosis? Fifi, what's your answer?
Laryngeal edema.
Exactly. Laryngeal edema. Why? Because of the chemicals. In contact with chemicals. And we were talking about the case of non-specific, something like that. Fifi made it clear to me that we can have I was thinking that chemical can only pass through, or they are just inflammatory. Inhalation, you can only just to inhale them. But of course, it can also pass through the GIT, isn't it? So some of these things can happen. And of course, when chemicals enter into the larynx, of course, edema can form. And of course, the larynx controls the voice. That's why we're having this stridor or voice hoarseness, the barking cough, because you're trying to remove whatever that is there or the fluid that is there. So you're having barking cough. And of course, your dyspnea will keep progressing and stuff like that. And again, if air is not entering, acrocyanosis will start developing, or cyanosis will start developing. So that is just how it is with this kind of questions. Over here, we are looking at what? Laryngeal edema. And again, we have done it. So let us not get confused. An 18-year-old woman complains of pain in her lower abdomen, purulent discharge from the vagina, temperature 37.8. Analysis states that she had random sexual contact. Random sexual contact. Some books, they will tell you sexually active. So the person had what? Random sexual contact the day before the signs appeared. That means she had unprotected sex. That's what it means, unprotected sex. And if you have unprotected sex, you can develop what? STI, sexually transmitted what? Infection or venereal diseases. Now, she was diagnosed with acute bilateral adnexitis. That means inflammation of the fallopian tube area. On additional examination, leukocyte in all the field of vision, bacteria. Guys, they've given you an answer here. Diplococci with intracellular and extracellular position. What agent is most likely in the given case? Guys, they've given you what? A diplococci bacteria. So what comes to your mind?
Gonococcus.
Gonorrhea. So gonococcus. Gonorrhea. So gonococcus should come to your mind. Gonococcus. Gonococcus. So the answer is E. A 45-year-old man, has been suffering from duodenal ulcer for years. Complaints of weakness, dizziness, dryness. But before I continue, who can tell me 3 complications of duodenal ulcer in every patient? 3 complications of duodenal ulcer.
Perforation,
Bleeding,
penetration,
and bleeding.
Penetration.
Fantastic.
bleeding.
Fantastic. So penetration, bleeding, perforation. Excellent. So these are the complications that might arise for people suffering from duodenal ulcer for quite a long time. Now he complains of weakness, dizziness, dryness of skin. Objectively, the skin and the visible mucosa are pale. There's chapped lips, heart rate is 100 per minute, pulse is 170, systolic murmur all over the point on heart auscultation. All other internal organs are unchanged. Fecal cord blood test is positive. Guys, even before I continue, what type of the complications are we looking at over here? Oh.
Bowel cancer.
Come again?
If the fecal occult blood test is positive, isn't that when they have cancer?
Bleeding.
Yes.
Bleeding is bleeding. So over here, we're having some signs of anemia. That's what I wanted to point out. And signs of anemia. Now, fecal cord blood test is positive, means that there is blood in there's hidden blood in the stool. That's what it means. Fecal occult means there's a hidden blood in there. That means you can't necessarily see it with the naked eye, but there's a hidden blood there. And it's positive. And look at the blood test. Erythrocyte is 3. Hemoglobin is 88. That is low. Blood, maybe we can say it's okay. The erythrocyte is okay, but the HB is quite low. Color index is low. Leukocyte is okay. Platelets, very much okay. ESR, 21 is quite okay. Now we're having what? Anisocytosis, poikilocythemia, serum iron. What treatment tactics would you choose? Don't forget, this person had what? Had a duodenal ulcer. So definitely you are thinking of what? An anemia. But the question is that what type of anemia? And I know when I talk about type of anemia here, you might be thinking of chronic post-hemorrhagic anemia, which you are absolutely what? Correct. But right now, they are not looking for that type of anemia, but that is correct. But we're not looking for that type of anemia. Now, if you are having mucosa, now in duodenal ulcer, what it means is that the mucosal lining is scraping off, or it's undergoing what? Erosion. And when it undergoes erosion, what happens? Some substances absorption will be impaired. Some substance absorption will be impaired. So that means that what comes to our mind here could either be what? Either vitamin B12 deficiency or iron deficiency. True or false? Oh,
True.
good. So we're thinking of B12 deficiency or iron deficiency. Now, if you talk about B12 deficiency, which of course, cyanocobalamine is actually another name for vitamin B12. Now, if you're thinking of B12, what should be your color index, or what do you look out for? Your color index, isn't it?
Like 1.2?
It should be, yes, more than 1. Exactly. So your color index will be more than 1. But here's the case. We're having color index even lower than normal. The normal is supposed to be around 0.8 to about 0.9 or 9.5, 8.5 to 9.5, something like that. But here we have what? 0.7. So again, we have 2 differentials, either B12 or iron deficiency. So of course, if it is not B12, then your answer is what? Iron deficiency. So how are you going to treat this person? Of course, iron preparation for balanced what? Diet. That's why over here, we would definitely go in for what? For C as our answer. Again, analyze the question. If you analyze the question, trust me, there'll be very, very small room for making errors. All right. A 58-year-old woman, hey, what do I like when mentioning woman? 58-year-old patient complains of headache in the occipital region, nausea, choking, tense. Presentation appeared after physical exertion. Patient is excited, face is apyremic, skin is pale, heart sounds are regular, second aortic sound is accentuated, BP 240, 120, heart rate 92, auscultation revealed some fine moist crackles in the lower lungs, liver is not enlarged. Now look at your ECG. ECG shows signs of hypertrophy and ventricular overload. So when we say ventricular overload, what comes to mind? Who can tell me? Ventricular overload. What is there that's making it overload? Who can tell me? Oh.
The question again?
When we're having ventricular overload, I mean the ventricle is overloaded. Overloaded with what?
With blood.
Exactly. That means there's too much fluid, too much blood inside the left ventricle. And again, there is what? Hypertrophy. That means there is thickness over that area. Isn't it? So the question is, what is the most likely diagnosis? Don't forget, this person is also having what? A BP of 240, 120. And we said, or I've mentioned that one of the complications of temperature, of BP is to cause a heart failure. It can also cause a stroke, heart failure, and it can also cause what? A stroke. So that is what we are looking at over here. So over here, we are having to call what? A hypertensive crisis. 240, 120. Now there's an organ damage. And that organ damage is now the heart. So now heart is damaged. It's now hypertrophied and it's now being overloaded with a lot of what? Blood. So that means it's not able to pump the blood for systemic circulation to take place. Why? Because of increased pressure. Or that is the risk factor. So we have what? A complicated hypertensive crisis. Now, in an uncomplicated crisis, it means that even though there is high BP, but there's no obvious organ damage. But as soon as you start seeing organ damage, ladies and gentlemen, we have what? A complication. Now, in some books, we describe these two as what? Hypertensive emergency and hypertensive agency. Hypertensive emergency, organ damage, agency, not obvious organ damage, something like that. So please take note of these two. Don't go and say this is myocardial infarction. No, this is not MI. This is not MI. This is not MI. Come again?
Why?
Now when we talk about MI, we are referring to what? Obstruction. We are referring to what? Obstruction. Basically, the coronary what? Artery or the heart muscles not getting the right amount of what? Oxygen. That is what comes to mind when you're talking about what? Myocardial infarction. That is what comes. So even though there's all of these things, and don't forget, there will be chest pain as well when we start dealing with this kind of what? Myocardial infarction. But over here, they said these presentations, that's occipital, headache in the occipital region, nausea, choking, and co. They come as a result after physical exertion. Now, what happens in physical exertion is that you are giving load to the heart. And when you're giving load to the heart, it means that your heart has to meet the metabolic needs of your body. Exactly. So that's what comes to. There's no really signs of MI in this question. That's why we can't go for MI or myocardial infarction. I don't know if I've answered your question, but if you're not clear, when we finish, just bring it up and then I'll take my time. So over here, we're looking at what? As C as our answer. C as our answer. 45-year-old patient, 14-year-long work record as a house painter. I think we have done this before. House painter. Upon the contact with synthetic paint, developed skin reddening, edema, severe itching, and oozing lesion on her face. Symptoms appeared after the contact with these chemical substances. Symptoms disappear. Symptoms disappear when after the contact with the substance stops. But even the smell of the paint alone is enough to make them reappear each time. So each reoccurrence is characterized by increased severity of symptoms. What provisional diagnosis can be made? And I think we discussed this thing. Then we're going, someone was asking, why is it not contact dermatitis? Because I was explaining that in contact dermatitis, when you come in contact with a chemical, just like in the case of our beautiful ladies who do the makeups, isn't it? Who do the makeups. And I'm sure that Bridget Dumpty has kind of such cases before, whereby their client is claiming that, oh, maybe the thing you sold to me is making me have some rashes on my face. I believe she might have had that kind of instances. But that is what? Contact dermatitis. But over here, that is not the case. This person has been working with these substances for 14 good years, and there were no case of such symptoms until recently. Then the person started developing all these symptoms. It's recently that the person started developing all these symptoms. And that's over here, because it is the person's kind of work. In other words, we call it occupational dermatitis or occupational eczema. Occupational eczema. But of course, Krok can be very, 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 very some way. But they chose to use a professional eczema. But I want to believe that the professional is referring to occupational eczema. Occupational. Why? This is because of overexposure to the thing has now developed a reaction to that substance or to those chemicals. And that's over here, we are looking at at a professional eczema or professional dermatitis. They all mean the same. A 32-year-old woman addressed a maternity clinic with complaints of infertility that has been lasting for 7 years. Her menstrual cycle occurs in 2 phases. Of course, that means it's normal. This is diphasic, isn't it? This is not monophasic. This is diphasic. Hysterosalpingography reveals obstruction of the uterine tube. So this is the reason why the patient is not getting pregnant. There is an obstruction. And over there is adhesive process. That means the tube have attached themselves together, or something has attached itself to those mucosal lining. And for that reason, we have an adhesive process. Adhesive process in the small pelvis. Now, what treatment is most advisable in this case? What treatment? Of course, now we're having a problem inside the uterine tube. So over here, it's not really a big case for you to open the woman up. No. This one, you can just use a microscope to view, or a camera to view that area. And that by using a camera, we're referring to a laparoscopy. We are referring to a laparoscopy, whereby you make a small incision in the abdomen or in the pelvis with the aid of a camera. And by doing that, you can remove that obstruction that is found in the uterine tube. And they even told you at the ampulla area. And you know this ampulla area, that is the area whereby fertilization actually takes place. Fertilization takes place around that area. So basically, if we remove that obstruction, the patient should be fine. No need to open up. So just do a laparoscopy. A survey radiograph of a 52-year-old worker of an agglomeration plant that has 28 years of experience. The concentration of metal dust is 22 to 27. Shows mildly pronounced interstitial fibrosis with diffuse constructs, well-defined small nodular shadows. Patient has no complaint. pulmonary function is not compromised. That means not yet compromised because it is mild. Mild. It is now mild. What is your provisional diagnosis? What is your provisional diagnosis? So here you think of what? Mental dust. So mental dust, what comes to mind? What about pneumoconiosis? Oh,
Cirrhosis.
exactly. So mental dust iron comes to mind. So we are thinking of what? Acidosis. Acidosis. And sometimes we also call it the Welder's disease. Welder's disease. Welder's disease. Again, pulmonary function is not compromised because this condition is what? It's mild. It's mild. It's mild. All right. So over here, your answer should be what? Should be D. Cirrhosis. Cirrhosis.